Welcome to this Beyond Zero e-learning module that is part of the Wits RHI e-learning catch-up sessions. This particular module is the first of two on significant drug interactions with antiretroviral drugs. And today we're going to be talking about basic pharmacology. So we need to start with some basic definitions. And the first definition you might remember from varsity days is your pharmacokinetic versus pharmacodynamic. Pharmacokinetic refers to what the body does to the drug, and pharmacodynamic refers to what the drug does to the body. So a good example to think of when you're trying to differentiate the two is what happens when you drink a glass of wine. So pharmacokinetic is going to talk about how your body is clearing out that wine. So it will tell you in terms of how long that wine is going to stay, or the effects of the wine is going to stay in your body, and exactly how hungover you're going to feel the next day. Pharmacodynamic has got to do with the effects of the alcohol on your body, so how it makes you feel, the side effects of the alcohol, if you could put it like that. And in the world of ARVs, this is a huge issue, is how the drug affects this body in terms of side effects. Second concept, when we think about drug interactions, which is what this presentation is all about, it has to do with how different drugs, when you're taking two different drugs at the same time, what kind of an effect they have on each other. And very simply, they either are additive or synergistic, so they increase the effect of each other or of the other drug, or they can be antagonistic or opposing. And if it was only this simple, it would make this lecture very short. But it gets a little bit more complicated, and we'll look at how these systems do interact. Third concept, which we won't use very much today, but is to remember about, is our first pass effect. So this is particularly valid for anything that we're taking through the oral route, medication or vitamins or even food. And everything that we take in has to go through the liver so that the liver can make sure it's not toxic to the body. And if the liver does find anything that's strange or does not seem to be nutritious, they will start to break those particular substances down. And that's the big challenge for pharmaceutical companies, is that whatever drug you might invent that's going to have a particular effect on the kidney or the brain or wherever you want it to work, you need to make sure it's going to survive the liver. And then the fourth slide is just to look a little bit about how we do metabolize and eliminate most of these drugs that we take. The body is very good and very clever in the way that it makes sure that foreign substances do not stay for very long in the system. And so they will firstly try and immobilize that particular substance, make sure that it's not active, that it cannot affect the body in some way. And they will try and make it more water soluble so it can be excreted. And although there are different places in the body where metabolism occurs, we can group them into two large types of reactions. So there can be largely liver metabolism happening in the liver processes, or it can be largely happening through conjugation, which is where you will start excreting it, for example, through the renal route. But both the liver and the conjugation routes eventually will eliminate it and can do it through any number of routes. So we're now going to focus on one of these metabolism systems, and we're going to focus on not the only one, but by far the most predominant one, and the one that gives us the most headaches from a medicine point of view, and that's a Cytochrome P450. So great. So what do you need to know about Cytochrome P450? What is it? So basically, it's a group of isoenzymes. So isoenzymes are the guys who's actually the workers in your body breaking down different substances or medication that you're taking in. And there are a whole group of them. So you don't only find them in the liver. The vast majority of them are in the liver, but you can also find isoenzymes in your small intestines, lungs, and even in the brain. And their function is to now alter these toxins or drugs or to speed excretion. So if you think of a large recycling factory, they are the ones who's actually going to take that particular medication or substance and change it, wrap it, break it down, and make sure that the body can get rid of it. We do have to name them to be able to describe them, and just like the geneticists, the pharmacists seem to like their numbers. So these enzymes have got code names. You can see there an enzyme might be called 3A4. 3 is referring to the family, A is referring to a subfamily, and 4 is referring to the individual gene. And this is something that we don't need to know in terms of managing our patients. This is very important within the pharmacology industry, is understanding all these different enzymes. But I'm not going to focus on them, and they're not important in terms of managing your patient. So if we can go back to our metaphor of using a recycling factory, we would imagine that there are lots of different isoenzymes. They've got lots of different names, and each isoenzyme is responsible for specific substrates or drugs that has to be metabolized. So you can see there's the names of the isoenzymes that are mainly responsible for drug metabolism. So similar to a recycling factory, you might have a specific factory worker who's looking after glass recycling, or a different one after tin and a different one after plastic. And similarly, within the P450, there's this differentiation of different isoenzymes. So they don't only metabolize medicines, also steroid hormones, vitamins, toxins, prostaglandins, fatty acids, pretty much anything that goes through the mouth. And we're going to look a little bit more that each of these isoenzymes, so imagine you've got your little factory worker sitting there with his particular tasks, and he has specific substrates, specific things that he has to break down. And there's possible inducers and inhibitors of that isoenzyme, and let's look a little bit more at that. So it would all be very simple if it was just a particular system, and whatever we put in the body gets broken down in a standard, predictable way. But unfortunately, the human body is not so predictable, and therefore we can't very accurately predict drug interactions. So if you were to look at alcohol, again being a very good example, all of us having maybe a glass of 2 of wine around the dinner table, there's going to be different things that's going to influence on how that drug interaction is going to happen, or on how well that drug is being broken down. So for example, patient factors, the size of the person, the kinds of diseases the person might have, whether they've had supper or not, environmental factors, whether they're smoking, alcohol is there as an additional factor as well. But also depending on how much wine you're drinking, the dose of the wine, over how long a period you're taking it, what kind of route you're taking it in. All of these factors creates a vast amount of variability. And that's probably one of the big challenges when we're treating patients. Although we can know of possible outcomes, we can't predict what's going to happen in a specific patient. Where drug interactions start becoming interesting is to look at how these different drugs have an influence on this P450 system. And for that, there are 3 very important concepts in terms of interactions. So the first concept is that of what we call the substrate. So to take us back to our alcohol example, if you've got a particular enzyme that's breaking down the alcohol is called the substrate. So your factory worker, if he's supposed to be recycling glass, glass will be his substrate. The next concept is that of an inducer. And your inducer and your inhibitors are drugs or medication or even food that you are taking that can have an influence on the factory workers. So they're actually having an influence on that specific isoenzyme. So when we're speaking of an inducer, the inducer is going to be speeding up that particular isoenzyme. So it's like giving the isoenzyme coffee. The isoenzyme is becoming more active, and what's going to happen is going to break the drug down quicker. Where the inhibitor is doing the opposite. The inhibitor is also having an effect on the isoenzyme, but it's actually going to make the isoenzyme sleepy. It's going to make the isoenzyme work much slower. So it's slowing the metabolism. And now what's happening is the substrate is not being metabolized as quickly and can build up in the body and cause toxicity and cause higher levels of that medication than predicted. So here's a nice little picture, and it can sometimes be confusing because inducers, which are making the isoenzyme work faster, is going to be reducing the dose of that particular substrate that the isoenzyme is working on. And so I would like to call those downers. So if you are taking a drug, a medication that's an inducer, it might down the drug levels of some of your other medication. And similarly, if you are taking a powerful inhibitor, which is inhibiting one of these isoenzymes, it's actually going to be boosting the dose or the drug level in the blood of that particular medication. And we had a slide earlier saying that all drug interactions are either additive or opposing, but as I've said, it's not quite so simple. So in practice, when you've got a patient in front of you, they might already be on a specific medication. You're now introducing another medication, drug B in this scenario, and there's a variety of things that can happen. So sometimes the drugs don't interact, especially if they work on different, they go through different metabolizing pathways, or it might be that drug A or B has got no effect on the CYP P450. Or you might have that there's an increased effect. So for example, taking simvastatin with ritonavir, you can have a decrease of effect. So that's when you, for example, with warfarin and rifampicin, or your PIs and rifampicin, or you could have a completely new effect because of the way that these isoenzymes are being affected. Let's make it more complicated. Firstly, remember that if an inhibitor is affecting a specific isoenzyme, it's obviously going to affect every single drug that isoenzyme is metabolizing. So it might affect a variety of drugs. Weirdly, you might have a substrate, so the isoenzyme has got a substrate that it's working on, but that very same substrate is going to affect that isoenzyme either by inhibiting or inducing it, which is causing like a weird loop system. Some inhibitors can affect more than one enzyme, and the effect can be dose dependent. So on a certain dose, all is fine, and then when you increase the dose, you start seeing problems. But most confusing of all, you can have one drug having inducing the isoenzyme of one particular substrate, but at the same time inhibiting another enzyme. So although we do say that particular drugs are mainly huge inhibitors or huge inducers, they might have different effects depending on the drug that they're being taken with. But you don't really need to remember all of that. The biggest thing you need to remember is that a drug interaction can occur in several circumstances, and if we don't think about it, we might miss it. So when you start a new medication, that's obvious. If somebody's already on a set of medications, if you're going to start a new medication, first question you want to ask yourself, may there be an interaction? But also remember, if you're stopping a medication, and our TB treatment is a very good example of that, when you stop rifampicin, it's got quite a powerful effect on many other drugs, and you need to make sure that some of those drugs might have to be readjusted. We need to think about it whenever we're changing the dose of a drug, and obviously also if we're changing a drug in a specific regimen. Something that's quite interesting is that inducing interactions tends to have a gradual onset or offset. So these are interactions that's going to be causing downers. It's going to be causing some of our drug levels to drop. So for example, it might lead to failure of your medication, but that might take a little while to develop. But interestingly enough, inhibiting interactions, so these are your boosters, that can happen quite quickly, which means you can develop toxicity quite quickly due to a drug interaction and need to watch out for that. If you have a big interest in pharmacology, you can actually go and look up each of those isoenzymes. You can look up what substrates they work on. You can look up lists and lists of what induces them, and you can look up lists and lists of what inhibits them. It gets very complicated, and it's not always helpful in a clinical setting. So we're going to focus a little bit on teaching you some of the main inducers and some of the main inhibitors that you need to remember, and a little bit the red flag scenarios where you just need to be able to think to yourself, oh, am I heading for a drug interaction? Do I need to perhaps look this up? So we start off with our inducers. So these are the guys who are speeding up those little isoenzymes, and so it's reducing the drug level in your blood. And the most famous one certainly are anti-epileptic drugs. And it's always a nightmare when we're taking anti-epileptic drugs with other medication, because quite often it's going to make our other treatment fail. The other huge inducer that we're going to talk about in a lot of detail in our next presentation is rifampicin and rifabutin, which is one of our cornerstones in TB treatment. And so whenever you start TB treatment, you've got to give a thought about rifampicin. In terms of ARVs, efavirenz and nevirapines are our most well-known inducers, but as I've mentioned earlier, they can boost in particular scenarios. I've got St. John's wort and garlic there in brackets. They are inducers, but they're not huge inducers, and they're not drugs that we use often. Griseofulvin is an inducer, also dose-dependent. I don't think it's available in the public sector any longer, so not such a major issue. So when we're thinking of major downers, so these are drugs that might make your other treatments fail. You're thinking of your epileptic treatment, TB treatment, and you're thinking about efavirenz. Next, we need to look at our inhibitors or our boosters, and these are our medication that might be making our little isoenzyme, our little factory worker fall asleep. Therefore, they don't metabolize the drug as quickly as they should, and the drug can build up in the body. And when you're thinking of inhibitors or boosters, you're thinking about toxicity. And by far the most famous one in our HIV TB scenario is that of ritonavir. And we actually use ritonavir for its boosting properties. As a matter of fact, the only reason why ritonavir is part of our ARV regimens is for its ability to boost some of the other protease inhibitors. Quite a few of our antibiotics are inhibitors. Probably the most famous one is erythromycin, clarithromycin, very dosing dependent. But ketoconazole, which is not so much used in our public sector, is also a well-known inhibitor. And then we've got inhibitors that we actually use all the time, but the effect is relatively small, and we use them for relatively short periods of time. So metronidazole is an inhibitor, cimetidine more so than omeprazole. And fluoxetine, haloperidol, and sodium valproate all have minor inhibitor possibilities. And boosters, therefore, is something that you will think about when you're using antibiotics, when you're using protease inhibitors, so for all of your second-line patients, and when you're using, for example, antacids, and a little bit to a lesser degree, some of your mental health drugs. We've talked about inducers, we've talked about inhibitors, but they're not going to be inducing and inhibiting all drugs. There will only be a problem with the drugs that are actually being digested or metabolized by our P450 system within the liver. And there are particular drugs that are quite vulnerable because that is where their main breakdown happens. And the most famous of all our vulnerable drugs is warfarin, and I think everybody knows this. If you start using warfarin with anything else, you've got to be very sure that there's no inducers or inhibitors there, especially because we need to keep the warfarin blood levels into such a narrow therapeutic band. Statins is another one that's digested by the liver and can easily be affected, as well as most of our antidepressants. So benzodiazepines, antipsychotics, fluoxetine, and amitriptyline, they're all broken down by the liver. Oral contraceptives, this is a big issue. You might have somebody on contraception, you start them on other treatment, and if you don't adjust their oral contraceptive dosing, they might very well fall pregnant on it. Very problematic, many of our cardiac medicines, amiodarone, a very famous vulnerable drug, as well as digoxin and our calcium channel blockers. Lesser known and sometimes forget about is our enzymes. It probably causes less of an issue because we use it for such short periods of times, and many, many more. So this is by no means an exhaustive list. But these are the ones that we need to be very much aware of. Another way of thinking about it is to look at which conditions that you are treating should flag you for possible drug interactions. And obviously, any cardiovascular disease management, any patient receiving TB treatment, any patient on PIs or NNRTIs, so your efavirenz and your nevirapine, patients with epilepsy, our mental health patients, especially with the benzos, contraception, antibiotics, especially with some of our antifungals, and to a lesser extent with analgesia. And there's a few resources. The trick with drug interactions is just to be able to ask yourself the question, might there be an interaction here? And if you're asking yourself that question, go and look it up. And there are some great apps, as well as websites, as well as the Medical Information Center, the National HIV and TB Healthcare Worker Hotline is staffed by pharmacists, and you can call them up and check whether you think there might be an interaction. Our next presentation is going to be focusing on the key hotspots, and it's going to be very practically orientated. So in which scenarios do we need to consider the possibility of drug interactions, and how do we need to manage those?